Thank you very kindly, Punima, for such a kind introduction. And I am particularly happy to be in this community of colleagues who are working to find ways in which we may be able to better support our marginalized communities and those who are vulnerable. I am absolutely thrilled to listen to the previous speakers and to watch the videos of some of the communities that I did work with in India some time back, and to also see that they are continuing to reflect about better ways in which they can achieve absolute good health. Now, having said that, I think I wanted to begin by saying that the COVID-19 situation has given us some critical points of reflection. And in my reflections going forward, I want to say that let us think about not only finding ways in which our marginalized and vulnerable communities should adapt, but also us as policymakers and implementers and designers should be able also to adapt and maybe be better servants of our marginalized communities. There are three things that I want to highlight initially that have been caused by this COVID-19 pandemic. Number one, we are now living in a scenario where individuals, marginalized communities, vulnerable communities, and even ourselves have started to rank our needs. The fact that folks are losing jobs, are losing opportunities, social networks are breaking, folks are beginning to rank their needs. And this may be significant to healthcare providers. For example, everybody now is looking for food. Everybody is thinking about their shelter. And those of our marginalized communities who have families are thinking about how do we sustain them. In that context, then you realize that our preventive and treating commodities, health issues are set on a back burner. And this is a big risk. The second one is that NGOs, and when I was listening to the video and reading the findings, I found the fact that NGOs are being asked now to think about being multidisciplinary rather than just being focused on health, and therefore we let other stuff out. Multidisciplinarism and multi-sectoralism. How do we work together with other sectors to now work in terms of pulling together so that we may be able to offer packages of services to our communities? And thirdly, which I am glad some of our speakers may have referred to, is to what extent do we improve the self-efficacy of our marginalized and vulnerable communities? And I like those who talked about human rights approach. What languages are we using? How are we considering our colleagues? Are they, in quotes, and excuse me for saying this, are they a third gender? Or should we talk about gender? Now, once we decide to talk about gender and that we've mobilized our marginalized communities along health, the issue then becomes, are we increasingly serving our populations to become dependent upon ourselves? Or in the course of serving our communities, we are giving them fish and teaching them how to fish? Excuse my symbolism if it's not appropriate in the context of vegan communities, But let's think about it in this particular form. So that when our marginalized communities feel that there are some services that they may be lacking because those services are provided only to a certain level of citizens who have an identification card, we should work in such a way that we are reminding our marginalized and vulnerable communities that they are part of this citizenry. And therefore, they may have the responsibility, and we facilitate them also to get those IDs. I wanted to highlight in my talk that during this pandemic, there are basically two things that happen, and we should probably look at COVID-19 in such a manner. COVID-19 brings about dangers or risks, let's talk about. And therefore, everyone is scared about the dangers of COVID-19. And when we were talking about the movements and the migrations of workers from, urban areas to their homes, there is a danger that they're talking about. I may not be able to pay my rent. I may be infected. I am vulnerable. And therefore, we move to another place where I may be able to have lesser, cost of life. So the first one is danger. I just wanted to put across in this webinar that if we concentrate on the dangers of COVID-19, we risk leading ourselves to situations of self-pity, and that these elements of self-pity may exacerbate our mental health issues. But COVID-19 also proffers us a different thing. It gives us opportunities. So there are dangers and there are opportunities. If we concentrate on looking at the opportunities provided, then we may be able to develop the self-efficacy of our communities. And so the summary probably of my reflections in this talk will be, to what extent do we balance our concentrations on the dangers of COVID-19 and the potential opportunities that COVID-19 provides, so that we have a balanced mental health going forward. And to do that, therefore, we must appreciate that there are some situations we are observing at the individual level that are dangerous and risky because of COVID-19. Our transgender, our men who have sex with men, our sex workers. There is increased anxiety and depression, and our colleagues have talked about lack of, economic access. Social and psychological problems. Our colleagues have talked about the ICTs that used to provide services now are closed. Healthcare providers may no longer be able to provide services as they used to do. There are disruptions on basic needs. And I think the world over, we are seeing people dealing with the issue of access to food, a very basic matter. So you can imagine the vulnerable communities, and once these basic needs are put out, then folks are having issues. Finally, there is anger, there is frustration, there is violence that's going on, there is further discrimination. But remember that our marginalized communities do live lives of discrimination, of anger, of stigma, even in normal circumstances. Now, this has been highlighted tenfold. So those folks who are talking of first, second, third gender are further pushing away our minorities. And therefore, we need to work in terms of that, ensure that our colleagues come to a balanced situation. So what are the potential solutions that I am seeking to suggest as we move forward. And I am looking at this from the point of view of the individual and sometimes also of the whole policy development area. Number one, how can we begin to reflect about home delivery of services to our marginalized and vulnerable communities? If we have sexual and reproductive health services and commodities that our vulnerable communities were receiving in the diocese, etc., can we begin to create networks of allowing and facilitating home delivery of contraceptives, of condoms, of PrEP, of HIV self-testing kits, so that we do reach out to where they are than waiting for them to come to where we are. Number two, we have been dependent a lot about working with the healthcare providers who provide us with competent screening and treatment options. Now, is it possible for us to begin to adopt self-care methods for health and well-being? Can we build the capacities of our transgender, of our MSM, of our sex workers to self-screen for HIV, for pregnancies, for STIs, so that we reduce A, the need for the healthcare provider, and B, therefore the time that may be needed in the interactions of the two. So self-care methods may be one way in which we will mitigate the problems of COVID-19. Thirdly, for our transgender who are on PrEP or on ARVs or on any other commodity issues, how do we begin to adapt multi-month drug dispensing opportunities? Rather than providing them 1 week or a monthly one, can we do 3 months? And then what are the potential issues or infrastructure that we need to put in place so that we mitigate that long period of time? Fourthly, virtual safe spaces. Because our transgender and their social links are being cut off because of COVID, can we utilize technology to create virtual communities so that our colleagues may be able to reach out to each other like we are doing right now, and therefore share in a confidential manner ways in which they can deal with their issues. The next two are in terms of food, and Punima talked about my hobbyist farming. But how are we able to adapt creative skills of agriculture, for example, multi-story gardening or vertical gardening, so that our transgender, our MSM, our vulnerable communities may begin growing their own food even when they don't have pieces of land? Can we have a sack, and out of that sack they grow their vegetables? Or on their walls outside, can they be facilitated to develop the skills to be able to grow a vertical garden, so that we are beginning to spread our disciplines as healthcare providers? And finally, let us work to facilitate our vulnerable communities to get government documents. It will be absolutely bad for us if our vulnerable communities and the stigma that they have and the discrimination they have further lack government services because they just did not access the government document like IDs. Let us mainstream the normal expected citizenry documentation into all our work. So thank you very much, and I welcome any reflections post this, and thank you for having me. Asanteni sana, shukria.